we know is hosted by the Gastro Foundation in association with Project ECHO at the University of New Mexico. These sessions are held weekly on a Wednesday. Please, the chat will be open for any questions, but even better if you could actually put your hand up and chat to us in person. We've got two speakers today. Both of them trained in our unit, so it's wonderful to have them both here. The first of our speakers is Dr. Thania Kahn. She's a gastroenterologist in private practice at Vincent Pallotti here in Cape Town. But of importance, she's just back from a year IBD fellowship at the very famous St. Mark's Hospital in London, which is, of course, one of the most excellent centers in the world for IBD. And Tanya's going to give us an approach to pouchitis. So Tanya, if you'd like to screen share, please. Tanya, are you screen sharing? And you're muted, by the way.
Okay, can you hear me?
Yes, absolutely.
And you can see the screen.
We can see your slides, but they're not. Yeah, that's perfect. Absolutely perfect.
Okay. So good afternoon, everyone. I'm going to be doing a brief case study with a review on pouchitis. So Mr. PD, he's actually a patient of Dr. David Epstein's. He's a 39-year-old male. He was 22 when he first saw David and diagnosed in 2007 with the first presentation of ulcerative colitis. He presented with acute severe pancolitis. He had IV steroids and was then started on azathioprine and Asacol. Unfortunately, he developed a steroid-dependent disease, and unfortunately at that time there were no other drug options. There wasn't really access to biologic therapy, so he underwent a colectomy followed by a two-stage ileoanal pouch anastomosis in 2009, and he did well post-op. He was then seen quite urgently by David in 2014 with acute onset lower thoracic pain. He was noted to have abnormal liver functions. He then had an ultrasound and a CT scan, which showed extensive portal vein, splenic vein, and SMV thrombosis with cavernous transformation. All his tests for thrombophilia were negative. He was seen by a vascular surgeon, started on warfarin, and he had subsequent recanalization of his portal vein. Gastroscopies showed extensive esophageal varices secondary to portal hypertension, and they were banded. He seemed to do well and then was seen again by David in 2020 with deterioration in his pouch function over the year building up to that. So he had rectal bleeding, also noted to have a severe iron deficiency anemia. And this was his pouchoscopy in August 2020, which, as you can see, showed extensive ulceration. He did have a normal pre-pouch ileum, and histology confirmed ulceration, and there were no features of definitive Crohn's disease. So he was treated with courses of antibiotics. He had oral budesonide. He was also put on oral pentasa, and his symptoms improved temporarily. He was also given IV iron therapy. His follow-up pouchoscopy a few months later, however, showed ongoing ulceration, and he had recurrent iron deficiency anemia. You can see how severe that is with a hemoglobin of 7.7 and a ferritin of 2.3. So he was started by David on biologic therapy with vedolizumab in January of 2021, and he had a good clinical response. And the scope at the end of 2021 showed also good healing. However, this year, again, unfortunately, symptoms have worsened. And when David saw him, he had a calprotectin of over 2,000, and this was his repeat scope. So as you can see, again, there's ulceration, inflammation, and the plan was to start him on an anti-TNF, but the patient has decided to hold off on this kind of treatment for now, and he wanted to explore some alternative routes, specifically diet. So that's just the brief presentation. So a restorative proctocolectomy with an ileal pouch anal anastomosis. We know it's the surgical modality of choice for refractory UC with histology proven dysplasia, as well as FAP. Pouchitis is a non-specific inflammatory process which occurs within the ileal pouch reservoir. And it's the most common long-term complication in patients who undergo this procedure. So it affects almost 50% of patients within the first 2 years, and up to 80% develop pouchitis symptoms at some point. Also, up to 50 to 20% of patients develop chronic pouchitis. A study looked at outcomes after proctocolectomy with a pouch, and it showed the prevalence of pouchitis in patients with UC who underwent the procedure increased over time, with a cumulative incidence rates of 25, 32, 36, 40, and 45% at 1, 2, 3, 4, and 5 years, respectively. It's also shown to have a substantial impact on the patient quality of life and also poses a high cost burden. So when we look at the pathogenesis, the intestinal microbiota, the intestinal epithelial cells, and the immune system of the gut play a crucial role in pouch homeostasis. So what happens is following closure of the ileostomy, the ileal mucosa of the pouch is unprotected from feces containing higher bacterial concentrations than the ileum of a healthy individual, and this occurrence is owing to relative fecal stasis in the pouch. So present evidence suggests that dysbiosis, along with colonic metaplasia and deficiencies of the innate and the adaptive mucosal immune systems, play a vital role in the pathogenesis of idiopathic pouchitis. Present hypotheses for the development of pouchitis include recurrence of ulcerative colitis in the colon-like reservoir, dysbiosis of the microbiota in the pouch, deprivation of short-chain fatty acids, mucosal ischemia and oxygen-free radical damage, a genetic predisposition, and immune dysregulation. Some risk factors for pouchitis development in patients with a pouch have also been identified, and they include a non-smoking status, NSAID use, and serum anti-neutrophil cytoplasmic antibodies. So for diagnosis, we can identify two main groups of pouchitis based on the cause, so idiopathic and secondary. In idiopathic pouchitis, the pathogenesis is unclear, whereas in secondary pouchitis, there's an association with a specific causative or pathogenic factor. So secondary pouchitis occurs in up to a third of cases, and it may be infectious, ischemic, NSAID-induced, collagenous, autoimmune-associated, or secondary to Crohn's disease. And occasionally, caphitis or irritable pouch syndrome can be misdiagnosed as pouchitis. So these are some photos looking at various pouch conditions. Top left, that shows a normal pouch body with a typical owl's eye appearance. Top right is a diagram of per photo of a pouchitis. Bottom left is a tip of J sinus tract. Bottom right is a perianal fistula at the anal verge. Top left, that shows caphitis. Top right, ischemic pouchitis. Bottom left, pre-pouch Crohn's ileitis, and then bottom right, pouch prolapse. So idiopathic pouchitis can be classified into types based on the clinical pattern, the presentation, and also the responsiveness to antibiotic treatment. So it can be active, inactive, presentation, if it's less than 4 weeks, duration is acute. If it's more than 4 weeks, it's chronic. Clinical pattern can be a single episode. Infrequent can be less than 3 to 4 episodes a year. Relapsing more than 4 episodes a year, or it can be continuous. And then you look at response to treatment as responsive or refractory. And then response to antibiotics, you can get antibiotic responsive or antibiotic dependent or refractory. And those are the basic definitions. So the diagnosis of pouchitis is based on the presence of symptoms, as well as endoscopic and histologic evidence of inflammation in the pouch. A combined assessment, including subjective and objective findings, has been recommended for the diagnostic approach. Overall, the endoscopy has been noted to be the most reliable tool in the diagnosis. So there are various scoring systems which can be used, and the Pouchitis Disease Activity Index, or the PDI, this is a validated scoring system, and it's the most commonly used. It's based upon particular subjective symptoms, also objective findings, as you can see on the right-hand side of the slide, and a score of 7 or higher is definitive of pouchitis. Interestingly, though, the presence of mild patchy edema and erythema are considered to be acceptable findings in a normal pouch. There's also the modified PDI score, which has been proposed, and this is to simplify the diagnostic criteria of pouchitis by omitting the histologic evaluation. Other scoring systems which have been used are the Heidelberg Pouchitis Activity Score. There's also the Chicago classification, which is based purely on endoscopic phenotype. So they will refer to a pouch as a normal pouch, or afferent limb involvement, or inlet involvement, or diffuse inflammation of the pouch body versus focal inflammation, or caphitis. So I thought this is a nice opportunity just to review how we should actually be assessing pouches when we do a pouchoscopy. Remember, the most common configuration is the J pouch, as showed in this diagram, and the stapled anastomosis is more frequently performed than a hand-sewn one. Other configurations include the S and the W pouch, and every now and then you will come across it. And the anatomy can be quite confusing during your pouchoscopy. So prior to performing the procedure, you give an enema, sedation should be used, and in patients who have strictures, you should use a G-scope or a pediatric colonoscope. Those are preferred. So we start off first with the anus and the perineum. So just examine the area for any perianal skin irritation. And this in itself can be a sign of poor pouch function. Look for previous scars, look for fissures, hemorrhoids, any signs of fistulizing disease or any collections. And it's very important that the skin be expected all the way anteriorly to the groin as well. Remember, anal strictures are common here, and usually this can be diagnosed with a digital examination. Some people divide them into rigid and non-rigid, depending on the presence of palpable fibrosis. And then remember also to assess the anal tone and the squeeze pressure. Here also there's the anal transition zone. So that's an area between the squamous epithelium of the anoderm and the dentate line below, and then the rectal columnar epithelium above. And it's typically about 1 to 2 centimeters, and it's best seen in a stapled anastomosis. So remember, this area, along with the cuff, has the potential risk of inflammation, dysplasia, and cancer. Then moving on to the rectal cuff, so inflammation here is called cuffitis. It's also a well-known and recognized complication of an IPAA. When you look at the anastomosis, you can look for pathology such as a pouch sinus, which can occur. Look for fistulas. Remember, they can involve the vagina, the skin, the urethra, prostate, or the gluteal muscles. Strictures are also common at the anastomosis, and they can occur in about 11 to 12% of UC patients. Then moving on to the pouch body. So this really is the main segment of the J pouch in terms of volume. And by insufflating this area, you want to assess the size and the distensibility of the pouch, because you want to, in that way, you're assessing or looking at pouch compliance, which is really the most important feature for pouch function. So for example, you'll be looking for a severely contracted pouch or largely dilated pouch. And strictures of this area are rare. If you do see them, then importantly think Crohn's disease. Then looking at the blind end of the pouch, so this corresponds to the efferent limb, also usually about 1 to 2 centimeters. Problems that can occur here, so you want to look to see if it's very dilated. Remember, stool can accumulate here, which can lead to incomplete emptying during evacuation. Sometimes it can also cause mechanical compression of the afferent limb, which can lead to obstruction as well. Then looking at the pouch inlet, so this is visible as one of the two typical, the owl's eye appearance. So this is the second most common site for stricture formation, which can lead to obstruction. It can lead to chronic evacuation problems, pouch dilation, and pouchitis due to bacterial overgrowth. Remember, all strictures need to be biopsied. And then finally, the pre-pouch ileum. So we intubate this area to look for various issues. So you want to look for any mechanical issues, so prolapse, intussusception. Sometimes this can also cause an acute angle. And then you want to look for any features of inflammation, so your ileitis, or any strictures, any polyposis. And here it's really important to look for any features of Crohn's disease. The various pro forma forms which can be downloaded from the internet, and I think they're quite important to use just for record keeping in your patients with pouchitis. So these are some pouchoscopy images. So the one on the left, that's a hand-sewn procedure, so there's no rectal cuff. The one on the right is a stapled anastomosis, so the rectal cuff is still in place. And just this is what a normal pouch should look like. So the Chicago classification here would be a normal phenotype, or it would have an endoscopic pouch score of 0. So moving on to management, we'll start with acute pouchitis. So 2 to 4 week course with metronidazole or ciprofloxacillin should be the first line therapy of acute pouchitis. High dose of VSL-3 has also been reported to be effective for treating mild acute cases. Other antibiotics have also been tried with success in small uncontrolled trials. So this includes your rifaximin, also erythromycin, tetracycline, augmentin have been used. They've all been used in clinical practice. In patients who have recurrent episodes, you should treat them with new courses of either the ciproflox or the flagyl, or you can use combination therapy. And in these patients, VSL3 can be used to maintain remission. Mesalamine enemas or suppositories, they have been used with some success. They can be effective, so it is worth trying. Then moving on to primary prophylaxis. So the probiotics VSL3 and Lactobacillus rhamnosus GG are widely used for the prophylaxis of pouchitis. Recently, the use of CBM as a probiotic has also shown favorable results in the prevention of pouchitis. Sulfasalazine has also been shown in a few studies to be effective in preventing the development of pouchitis. So I think it is important just to bear all of these options to keep them in mind. So what about the treatment of chronic antibiotic-dependent pouchitis? So importantly, exclude your secondary causes. And usually in these patients, agents with favorable safety profiles are used. So this would be your rifaximin and your probiotics. You can use chronic antibiotic therapy. So you want to do it as use it at the lowest dose of antibiotics. So this would be Cipro 500 daily or 250 PD. You can also use a cyclical course of antibiotics. So cycling from one antibiotic to another every 1 to 2 weeks. And you have some periods and intermittent week off. Corticosteroids are another option, and the preferable one would be budesonide. And then if you need to escalate therapy, you would then be looking at advanced immunosuppressant therapy. What about the treatment of chronic antibiotic refractory pouchitis? So again, very importantly, you need to do a thorough investigation to rule out secondary causes. These patients can be very difficult to manage, and usually they are treated with medications for ulcerative colitis or Crohn's disease, which include your corticosteroids, your immunomodulators, and then your biologics. So in a retrospective multicenter study by Messinero et al. This year, they evaluated the effectiveness and the safety of azathioprine as maintenance monotherapy in inflammatory pouch disorders. 63 patients were included, and the rate of clinical response, remission, and non-response at a year were 52%, 30%, and 18% respectively. They then were followed up, there was a median follow-up of 23 months. 30% were in clinical remission, 66% stopped therapy, and endoscopic changes were evaluated in 19 of the cases, and they showed a p-die score which decreased from about 3 to 1. In 21 patients, they presented with adverse events, and 16 patients needed to stop therapy. So moving on to biologic therapy. So this was a comprehensive systematic review and a pooled analysis of real-world studies evaluating biologic therapies for chronic pouchitis. So the primary outcome, they looked at clinical response, which was assessed in 13 studies, and those treated with infliximab and vedolizumab made up the two largest proportions of the sample. The overall pooled clinical response rate was 46%, and then the individual clinical response rates were infliximab 41%, vedolizumab 42%, adalimumab 26%, and ustekinumab 59%. They also looked at secondary outcomes. Clinical remission was studied in 17 studies. 402 patients were included. Again, also the majority of patients received infliximab or vedolizumab. And there again, you can see the pooled remission rate was 35%. And then for the individual agents, 51 for infliximab, 13 vedo, 34 adalimumab, and 7% ustekinumab. Endoscopic response was another secondary outcome that they looked at. 11 studies were included, overall response rate of 41%. And then you can see the individual rates on the screen as well. To date, there's only one published well-powered RCT, which shows the efficacy of vedolizumab in inducing remission in patients with chronic pouchitis. It's the well-known EARNEST trial. So among the 102 patients who underwent randomization, the incidence of the modified p-die defined remission at week 14 was 31% with vedolizumab and 10% with placebo. Differences in favor of vedolizumab over placebo were also seen with respect to the MP-die defined remission at weeks 14 and 34 as well. What about other treatments? So topical tacrolimus, there was a systematic review which evaluated the current state of the literature, which looked at the safety and effectiveness of rectal administration of topical tacro in the form of suppositories, ointments, and enemas. And they looked at this in patients with ulcerative proctitis, perianal Crohn's disease, and chronic refractory pouchitis. And clinical remission was found to be achieved in 57% in patients with the ulcerative proctitis, 57% in patients with a fistulizing perianal disease, and 70% in patients with a chronic pouchitis. The most commonly reported side effect was perianal itching and burning, and reversible nephrotoxicity occurred in a single patient. What about FMT? So one prospective placebo-controlled double-blind trial of patients with antibiotic-dependent pouchitis received a single endoscopic FMT followed by daily FMT for 2 weeks, but the study ended prematurely due to failure of response for the first 6 patients who were enrolled. Several other studies did show significant did not show significant improvement in the PDI scores. However, Salvig et al. Did report improved bowel frequency in their cohort of patients. In a systematic review of 9 studies, which included 14 patients who had FMT, which was used to treat chronic pouchitis, clinical response after FMT was reported in 32% of patients and clinical remission in 23%. Most of these studies were case series or case reports. And then there's the alicaforcin enema. So this is a human ICAM1 oligonucleotide. It's a therapeutic target in inflammatory bowel disease and pouchitis. Remember, so it's a transmembrane glycoprotein on the surface of the intestinal epithelial cells and the vascular endothelial cells, and it's involved in leukocyte adhesion, migration, stimulation, and trafficking. So in 2004, Minor et al. Conducted an open-label, uncontrolled study in 12 patients with chronic refractory pouchitis, and these patients received 240 milligrams nightly for 6 weeks. At week 6, 58% of patients were in remission with an average decrease in a PDI score by 6 points. In 2019, a phase 3 randomized double-blind placebo-controlled trial evaluating these enemas for treatment of active chronic antibiotic refractory pouchitis did not reach the primary efficacy endpoint of reduction in bowel frequency at week 10, nor did they reach endoscopic remission. And this isn't approved for use in pouchitis. And then I thought I would just end off. So these are the AGA clinical practice guidelines on the management of pouchitis. It was released earlier this year. So most of the evidence base for therapies is primarily derived from retrospective observational studies or comparisons of small cohorts. So they released these guidelines informing on management guidelines. So they had a few key considerations. They advised that with regards to normal bowel function after the procedure, so they will have an initial period of post-op adjustment, but after this, patients can expect an average of 4 to 8 bowel movements per day and 1 to 2 bowel movements per night. Typical symptoms of pouchitis include increased stool frequency, urgency, low abdominal pain or cramping, and or pelvic discomfort. And importantly, clinical symptoms of pouchitis do not necessarily correlate with endoscopic findings. With regard to endoscopic evaluations in patients with pouch disorders, so the panel felt that pouchoscopy should be performed in patients experiencing frequent recurrent episodes of pouchitis. So basically in your chronic antibiotic-dependent pouchitis. It should also be performed in your suspected chronic antibiotic refractory pouchitis, in patients experiencing atypical symptoms of pouchitis, and in the diagnosis of Crohn's-like disease of the pouch if that's being considered. With regards to treatment goals, so they felt that the overall goal of treatment in patients with pouchitis is resolution of symptoms. So there is emerging data that resolution of endoscopic and histologic inflammation may be associated with a low risk of future episodes of pouchitis, but they did not consider this a critical outcome for decision making. With regards to the use of calprotectin and other biomarkers, so prior studies have demonstrated that fecal calprotectin is correlated with the PDI score, and that these levels actually have been shown to elevate before clinical diagnosis of pouchitis. Lactoferrin also appears to increase before diagnosis of pouchitis, and it also correlates with endoscopic inflammation noted on pouchoscopy. And then importantly, they again emphasize on an investigation of alternative etiologies. So just in general, your infections, any mechanical issues, evacuation disorders, and then of course Crohn's disease. These are the definitions that they've suggested. Just for time's sake, I'm not going to read through that, but the terms used were intermittent pouchitis, and then your chronic antibiotic dependent and refractory pouchitis, and your Crohn's-like disease of the pouch. So just in essence, their guidelines. So with regards to primary prevention of pouchitis, they made no recommendation in favor of or against the use of probiotics, and they advise against the use of antibiotics in the prevention of pouchitis. With regards to treatment, in patients with infrequent episodes of pouchitis, they suggest the use of antibiotics for treatment, and they don't make a recommendation for or against probiotics as treatment. However, in patients with recurrent episodes of pouchitis who do respond to antibiotics, they do suggest probiotic for prevention of recurrence. In patients who have the antibiotic-dependent pouchitis, they suggest chronic antibiotic therapy. So again, at the lowest dose of antibiotics or cyclical course of antibiotics with intermittent periods off the antibiotic. Again, if you need to escalate that or no response to the chronic antibiotic therapy, you'd be looking at your advanced immunosuppressive therapies. Patients with the refractory pouchitis, they suggest advanced immunosuppressive therapies. They suggest corticosteroids. And again, your controlled ileal release budesonide is preferred formulation and a short duration, less than 8 to 12 weeks. There's no recommendation in favor of or against mesalamine. And then for Crohn's-like disease of the pouch, they suggest the use of corticosteroids and then immunosuppressive therapy. And then just to end off, this was quite a nice pouchitis treatment algorithm I found. And yeah, I think this will go up onto the iEcho website. Thank you.
Thanks, Thania, for a very comprehensive presentation. There are no questions in the chat, so I'm going to take the liberty of asking you a few. So obviously, ileal pouch anal anastomosis is not a cure. So we need to be very careful to tell our patients this is not a cure. A cure means you're going to get somebody back to their pre-morbid condition, and passing 6 to 8 schools a day is clearly not what a normal functional human being would expect. So what's your feeling that we should rather be moving towards ileorectal anastomoses? I know our surgeons are getting sort of increasingly unhappy to do pouches because of the complications.
So where, Prof, you're asking, should we be moving to ileorectal?
Ileorectal, yeah, or have a lower threshold to try that.
Honestly, I mean, I'm not too sure. In my limited experience, I can't really.
Yeah. I don't think anybody's too sure, but I think pouches are so problematic that it might not be an unrealistic thing to do. So just one other thing, was there any cross-sectional imaging to exclude any peri-pouch sepsis or any sepsis done in this patient?
So I'd have to, I'm not sure if David's on. He was going to join the chat, but I'm not too sure. You mean just looking for sort of collections and other out here? I'm not too sure.
I'm pretty sure he would have done it.
Yeah.
And then just one last question. Why is pouchitis so much higher with patients who've had ulcerative colitis than it is with, for example, FAP? Is it a microbiome thing?
I mean, I guess the assumption would be, it is that. Because, yeah, I think the rates, you saw the rates of pouchitis in UC. Patients with FAP, I think, have an incidence of about 10%. Yeah, I would be assuming microbiome, something.
I assume since antibiotics are effective in patients.
Yeah.
Great. Well, thank you very much. We need to move on in the interest of time. That was great. So our next speaker is Cecilia Coccia. So she is a consultant gastroenterologist. She also trained in our unit, as I mentioned earlier, and she's currently working in Windhoek at the Windhoek Digestive and Liver Institute in Namibia. And she's going to chat to us on is it the disease or is it the drug? So Cecilia, if you would like to screen share, please.
Okay, I assume you can hear me and you can see my screen.
We can do both.
So my talk's a lot quicker than Thania's. I just thought it was 2 patients that were quite interesting because I've never come across it. So I'll just discuss them, and then it's also just to get your opinion on the matter. So the first case is case TM. She's a 41-year-old German lady who is currently in Namibia on a work contract, and she was staying about 4 hours drive from Windhoek in a more rural area. She had no comorbidities, no previous surgery, no significant family history, and she was a non-smoker and of sober habits. So Essentially, she presented to a surgeon in Swakopmund with a several-month history of diarrhea and rectal bleeding. It wasn't really that bothersome because, according to her, she didn't really have time to sort it out when she was still in Germany, and she sort of was just carrying on with her life. So eventually she underwent an elective colonoscopy by a surgeon on the 28th of March this year, done in Swakopmund. And he basically described it as having coarse and edematous mucosa involving mostly the rectum and the sigmoid with a patch near the hepatic flexure. But the histology was in keeping with UC. There was active colitis with cryptostortion and ulceration. So he commenced her on Asacol 800 milligrams QID and prednisone 40 milligrams daily. And he gave her a letter to say, suggest seeing a gastroenterologist. And then he sent her back off into rural Namibia. So about a month later, she was transferred down to me. I admitted her on a Friday afternoon. She had stopped her prednisone about 2 weeks prior due to side effects. These side effects she described as worsening of her diarrhea and her rectal bleeding. She was now passing 8 bloody stools per day, where previously it was about 3 or 4. Clinically, she had a pulse rate of 105. Her hemoglobin was 7.6. She had a CRP of 173, and her fecal calpro ended up coming back as 2,200. She also said that she had developed a maculopapular rash. It was sort of scaling, and it was on her face, her chest, and her back. And then she'd also said that she had weakness of her lower limbs with a loss of sensation. And so she'd attributed this all to the prednisone and had stopped it about 2 weeks after therapy. So I started her on IV hydrocortisone despite her fears of the prednisone causing it. And seeing as she was already on the Asacol, I continued it, but I upped it to 2 grams BD instead of the 1.6 BD that she was on. She got 2 units of red blood cells plus Cosmoper during her admission. So the next day after starting the hydrocortisone, her stool had actually already dramatically improved. She'd only had sort of one stool overnight. And by day 3, she had complete resolution of her diarrhea. Her pulse rate had come down nicely to less than 90, and her CRP was still above 45, but it had come down from 170. But what was noticeable was that her rash was definitely worsening while she was in hospital, and so were her liver functions. So at day 5, based on that, I decided, the only culprit that I could think of that was doing this was the Asacol. So I stopped it and subsequently saw a gradual improvement in the rash, the LFTs, and her peripheral neuropathy. So I know this is very, very small, but if you look at the first big chart, the results go from right to left. On it, or the day before admission, her ALK phos was 148, her GGT was 132, and she had an ALT of 64 with an AST of 36. So essentially a mixed picture. And then during the admission, essentially the ALK phos went up to 170 and then peaked at 182, and the ALT went up to 128, 155, 179, and that was when I decided to stop it. And you can see that sort of 2 days later, there was already a dramatic improvement with the ALT coming down to 120 and then subsequently 71 and then normalizing. Obviously, I also just excluded any other causes for the peripheral neuropathy. So her B12 was normal, her folate was normal, and her thyroid function was normal. And then in terms of the liver injury, her Hep B and C were negative, and her autoimmune liver screen was also negative. So that was the first case, and I've had patients that have had renal injuries with Asacol, and I've had patients that have had worsening of their UC, but I've never had anyone with a peripheral neuropathy and such an extensive rash. So then the second patient is case RE. So she's a 26-year-old nursing student, also very far out of Windhoek, so she stays even more rural, about 6 hours away. Medically, she just had a history of PCOS. She had no previous surgery, no family history, and she was also a non-smoker with very minimal social ethanol. So she presented to me with a 4-year history of rectal bleeding. During that time, she probably had about 7 or 8 colonoscopies, where all of them had shown chronic proctitis. But during that course, she'd had intermittent courses of oral Asacol, but due to no improvement, it was stopped. So then on the 30th of April, I did a colonoscopy. Essentially, she just had a Mayo 2 to 3 proctitis in the distal 5 centimeters. And it was also in keeping with UC, so there was crypt distortion and branching with some cryptitis. So essentially, I just started her on Asacol suppositories, and she had a good clinical response. So again, now with her, if you see sort of again in the first table on the right-hand side, the first three values were prior to me seeing her, where you can see that there's these dramatic increases in both her GGT and her ALT. Again, a mixed picture, and it's difficult for me to know if this correlated to the periods where she received oral Asacol. But then on seeing me, the 29th of the 4th, her ALT was 13 and she had a GGT of 81 with an ALK phos of 131. On commencing the suppositories, you can then see that her LFTs go off with her ALT peaking at 87 and her GGT peaking at 356. I then didn't see her for a while because she kept defaulting follow-up. And when I saw her recently now in November, she'd been off therapy for a month because she struggled to get it. But again, there was a dramatic improvement in her LFTs. Okay, with her, I also excluded Hep B and Hep C. And other than a positive ANA with a titer of only 80, the rest of her autoimmune liver screen was negative. So I went on to do a liver biopsy just to make sure that this wasn't an autoimmune hepatitis brain. And essentially the features just showed a mild steatohepatitis with some eosinophils. And so the final comment was that it was more in keeping with a drug-induced hepatitis than autoimmune or anything else. I did an MRCP just to make sure that there wasn't a PSC, given that it was a predominantly canalicular pattern, and that was also unremarkable. So then with both of these cases, I decided to try my best to find as much information as I could, and there really isn't much out there. So I found a systematic review done by Colombel et al., which showed discussing the safety of mesalazine in ulcerative colitis. And they basically had a table of the adverse events. And in this table, I could find paresthesia and pruritus, and that was 0.5%, but no specific peripheral neuropathy was noted. There were elevated LFTs which were documented, and that occurred in about up to 3% of patients. And then there was also a UC exacerbation that can occur with Asacol in up to 6.5% of patients. So when I looked at SAPRA and their drug information, they do document peripheral neuropathy as a very rare side effect of Asacol. And then they also describe the liver injuries as very rare. Whereas more commonly a rash, pruritus, and urticaria can occur. So when I tried to find case reports of peripheral neuropathy due to mesalazine, they were very, very, very scant. So these are essentially the three I could find. In the first one, they referred to one other case, which they didn't reference. In the article from 1989, they said that there were two other cases that had been reported. And in the one at the bottom, which wasn't even really in English, they described two other cases, which again weren't referenced. So then I looked at peripheral neuropathy in IBD, also not very commonly discussed, but I did find a nice review article just going through peripheral neuropathy associated with GI disorders. Specifically IBD. And then I found one case report on an acute sort of sensory polyneuropathy, which is similar to what my first patient had. So then just to discuss peripheral neuropathy in IBD. So in that article, they actually said that there's an incident rate of about 72 cases per 100,000 person years with a cumulative incidence rate of about 2.4%. There are various clinical presentations, so you can have sensory, motor, autonomic, and mixed, and that can be axonal or demyelinating. You can have an acute or a chronic presentation, and then they can also develop carpal tunnel syndromes. So what they found is that the neuropathy is often not related to disease activity, and it doesn't respond to the treatment of the underlying IBD. The most common causes are immune mechanisms, iatrogenic, micronutrient deficiencies, and then drug-induced. And the most common culprits they described are anti-TNFs, metronidazole, cyclosporin, and thalidomide. And then obviously the management just depends on the cause of presentation. So if there's micronutrient deficiencies, you'll obviously treat that. And if you have a severe neuropathy that doesn't respond to steroids, like in my patient, then you would probably escalate to immunoglobulin therapy. So in terms of liver dysfunction and mesalazine, so the incidence of elevated liver enzymes has been reported in the range of about 0 to 4%. It's usually a cholestatic pattern, but it may cause a transaminitis. And then on a few case reports, they've indicated that it causes a granulomatous hepatitis on biopsy, which would essentially explain the mixed picture. So the management, if there's a mild increase in liver enzymes, essentially they suggest continuing it. And if there's a significant transaminitis, then to discontinue it. And if there's no improvement, then to start systemic steroids to treat the induced hepatitis. They also say that if there is a clear sort of correlation between starting the drug and the liver injury, that a liver biopsy is not necessary. It's just to sort of manage the patient clinically. And then looking at liver dysfunction in IBD itself, obviously we know that in IBD there's a lot of extraintestinal manifestation, and the liver is one of them. So in UC, it's always important to think of PSC, autoimmune hepatitis, as well as overlap syndromes, to think of PBC, and then in an acutely unwell patient, not to forget portal vein thrombosis, and then obviously NAFLD. And then the same thing in Crohn's disease, but they can get a granulomatous hepatitis. They can also get liver abscesses, especially if they've got fistulizing disease. They're more prone to getting gallstones, as well as hepatic amyloid. And then it's also just important to remember drug-induced liver injuries in both, as well as Hep B reactivation. So just going back to my question, is this disease or the drug? So in my opinion, in both these cases, I strongly think that Asacol is the culprit. So my first patient, Mrs. TM, so prior to starting the Asacol, she had several months of GI symptoms without any systemic symptoms. She also had a worsening of her GI symptoms immediately after commencing the Asacol. I mean, that might have been a temporal or just her disease progression. But to me, it was sort of she'd been well or relatively well up until that point. And then her symptoms and biochemistry initially worsened despite IV hydrocortisone. And then there was a rapid improvement on the withdrawal of the drug. And then in the case of Mrs. R.E., as I mentioned earlier, there was an unclear timeline prior to me seeing her. So it was very difficult to correlate whether the oral Asacol had impacted her liver function. But what I did note that was since I started the suppositories, it worsened. And when she defaulted therapy, it improved. The liver biopsy was also suggestive of a possible DILI. And in her case, it's just difficult because I'm not certain what other treatment options there are for her. I know Dion gave a talk, was it last week, on treating, just a UC proctitis. And I mean, it's hard enough getting this lady the Asacol suppositories in the rural areas, and never mind contemplating things like topical Tacro. So that's my presentation. I just thought it was quite interesting because I've never seen reactions like this to Asacol, and I think it is just something to bear in mind that this innocent drug can sometimes not be very innocent.
Thanks, Cecilia. Those were really fascinating cases. And I must say, I certainly have never seen Asacol causing a peripheral neuropathy. And I have seen a couple of drug-induced liver injuries, but very uncommonly. And we always feel very comfortable using this drug, but we mustn't be complacent, as you said. So just a couple of things. You mentioned Dion's excellent talk, which is actually should be on the website, and he mentioned Terry Proct suppositories, which I've had great success with over the years to treat proctitis, because it's the only way that you can deliver a topical steroid. The enemas, of course, just bypass the rectum, so I would suggest that. If she hasn't tried that, I think it's an excellent option. And then from your reading around this, how often should we check LFTs? It's been my sort of practice just to do them once a year if they've been normal in the past on a 5-amino salicylate. But what was your feel from the literature?
So, I mean, again, it's like obviously in the patients on sulfasalazine and methotrexate, you keep a much closer eye because you expect it. And I mean, to be honest, in my clinical practice, I've pretty much done obviously the same as you, where it's just sort of every 6 months to a year, you might just do an ALT or an ALK-Phos. Also just to make sure that they're not sort of developing an autoimmune hepatitis or a PSC in the background. But in the literature, as I said, I mean, it was so scant that there's no real recommendations. It just sort of says, if it happens, then this is what you can do. But weird things happen in Namibia. So I don't think anyone else is going to find a peripheral neuropathy due to Asacol.
I'll let you know if I find one. So let me just see if there are any questions in the chat. Does anybody have any questions for Cecilia or for Thania? Doesn't look that way. Everyone's being very quiet today. So in that case, we're going to finish up a little bit earlier. So firstly, thanks very much, Cecilia and Thania. It really is greatly appreciated. I'm struggling to fill the slot and you guys came to my rescue. So thank you. Also, thanks to iEcho University of New Mexico and the iEcho India team. The recordings, as I mentioned, will be available on the website. Thanks, of course, to the Gastro Foundation. Thanks to Cheryl and Carol for setting everything up. And, of course, thanks to the sponsors. So the next week's iEcho session will be pathology, and this will be the last session for 2024. So thanks, everybody, for joining us, and I do hope you have a good evening. And from the IBD side of things, we shall see you in 2025. So have a fabulous Christmas and New Year.
Thanks, Jill.
Thanks, Prof.
Thanks
Bye.
for doing it.
Cheers,
Bye.
everybody. Bye.